Welcome to the deep dive. Today we're tackling a really crucial topic, esophageal varices. Super important if you're prepping for exams or, honestly, if you just want a solid understanding of this condition.
Exactly. Think of this as your focus session. We're aiming to pull out all the core info, what they are, the causes, symptoms, how we manage them.
Yeah, cutting right to the chase. And we're using materials like MSRA revision notes, so it's geared towards that high-yield knowledge you need.
Precisely. So we're really focused on extracting the essentials for effective revision and, practical understanding.
Okay, let's jump in. Esophageal varices. In simple terms, what are we talking about?
Well, they're basically swollen veins,
Yeah,
dilated veins, you could say,
right.
located in the wall of the esophagus, but specifically the lower part, the tube from your mouth down to your stomach.
Got it. Lower part of the esophagus, and the main reason they get swollen like that.
The key driver is something called portal hypertension.
Portal hypertension.
Yeah, it just means there's high pressure in the portal vein. That's the big vessel carrying blood from your gut, spleen, pancreas towards the liver.
Okay, so pressure backs up. And where exactly do these swollen veins, these varices, actually form?
They pop up right at the connection point, the junction, between that portal system and the normal systemic venous system.
Ah, where the two systems meet.
Exactly. It's where the blood, under that high portal pressure, tries to find sort of alternative routes back to the heart.
Like a detour because the main road is blocked. Clever, but causes problems here. I actually have a mnemonic for that. It's a bit cheesy, but maybe helpful.
Go on.
Dilated veins, low down, portal pressure clown, junction. Might help someone remember the location and the cause.
Whatever works.
Yeah.
It highlights the key bits. Lower esophagus, portal pressure, junction.
Exactly. Okay, so let's dig into why that portal pressure goes up. What are the actual causes?
Right. So fundamentally, it's anything that obstructs blood flow through the liver or increases flow into the portal vein. But the most common cause, certainly in places like the UK, is severe cirrhosis of the liver.
Cirrhosis, that scarring of the liver tissue.
Precisely. Usually from things like long-term heavy alcohol use or chronic viral hepatitis like hep C or B. That scarring just makes it hard for blood to get through the liver.
Okay, so cirrhosis is the big one. But you mentioned other ways portal hypertension can happen.
Yeah, absolutely. We often categorize them based on where the issue is relative to the liver. So you've got pre-hepatic, intra-hepatic, and post-hepatic causes.
Before, within, and after the liver makes sense.
Exactly. So pre-hepatic, before the liver, you could have a blockage, an obstruction in the portal vein itself. Or maybe a blood clot thrombosis in the portal vein or the splenic vein.
Okay.
Also, something called schistosomiasis. It's a parasitic infection, not common as a cause here, but globally, it's actually the most common cause of non-cirrhotic portal hypertension. So high pressure without the liver scarring.
That's really important to know, especially the global context. Any other pre-hepatic causes?
Well, sometimes you can get fistulas, like abnormal connections between arteries and veins that just dump extra blood into the portal system, raising the pressure.
Right. Okay, what about intra-hepatic, inside the liver itself?
That's primarily cirrhosis, as we said, whatever the cause, alcohol, viruses, fatty liver disease, autoimmune conditions. But you can also have alcoholic hepatitis, which is inflammation without full cirrhosis yet, or idiopathic portal hypertension, where we sometimes don't find a clear cause.
And finally, post-hepatic, after the liver.
Yeah, so this is blockage after blood has gone through the liver. Think Budd-Chiari syndrome, clots in the hepatic veins draining the liver, or maybe a liver tumor pressing on those veins.
Oh, compression.
Exactly. Or even things further away, like constrictive pericarditis affecting the heart, severe right heart failure causing backup, or even pancreatitis sometimes. Rarely, umbilical vein sepsis in newborns can lead to a specific type, left-sided portal hypertension.
Wow, okay. It's quite a list. It really shows how interconnected everything is. Here's a quick question for you listening. A patient from South America presents with upper GI bleeding and is known to have non-cirrhotic portal hypertension. What's a likely cause for their varices? Think about what we just discussed.
Good one. Likely schistosomiasis in that context.
Okay, moving on. What factors increase someone's risk? We know the causes, but what makes someone more susceptible to portal hypertension and these varices?
Well, the biggest risk factor is having cirrhosis, obviously.
Yeah.
So anything that causes chronic liver disease, alcohol, viruses, etc., puts you at risk.
Makes sense.
But also, things like being malnourished can play a role. If someone's existing liver disease suddenly gets worse, we call that decompensation. That's a risk factor too. Even increased pressure inside the abdomen for various reasons. And interestingly, using aspirin or NSIs regularly has been linked to increased portal pressure too.
Okay. And what about the risk of the varices actually bleeding? Because that's the really dangerous part, isn't it?
Absolutely. The bleeding is the major complication we worry about. Key factors that increase bleeding risk are, number one, how high the portal pressure actually is. Higher pressure equals higher risk.
Logically.
Number two, the size of the varices themselves.
Yeah.
Bigger varices are just more likely to rupture. Simple physics, really.
Yeah.
And then, unsurprisingly, having more advanced liver disease, like more severe cirrhosis, increases the risk. And crucially, if someone has already had a variceal bleed in the past, their risk of bleeding again is much, much higher.
Right. A previous bleed is a strong predictor. Got another memory aid for this. Risk of pressure and size leads to bleeds in advanced disease with past deeds. Hopefully helps tie those factors together.
Nice one. Pressure, size, liver severity, and previous bleeds. Those are the key things.
So we know what they are, the causes, the risks, but how do they actually form? What's the sort of mechanism, the pathophysiology?
It all comes back to that portal hypertension, usually from cirrhosis, like we said. The scarring in the liver blocks normal blood flow.
Our blocked highway analogy again.
Exactly. The traffic, the blood gets backed up. Now, why the lower third of the esophagus specifically? It's the end of the plumbing, the venous drainage.
Okay.
The upper two-thirds of the esophagus drains blood mainly into the azygos vein, which goes to the superior vena cava part of the normal systemic circulation.
Right.
So no high pressure there, generally no varices.
Right.
But the lower third, that drains into superficial veins in the esophageal wall. And these connect to the left gastric vein, which flows directly into the portal vein.
Ah, so that lower bit is directly linked to the high-pressure portal system.
Precisely. Normally, the pressure difference, the gradient between the portal vein, maybe 9 mmHg, and the inferior vena cava, say 2 to 6 mmHg, is pretty small, like 3 to 7 mmHg.
Okay.
Portal hypertension is defined when that gradient gets above 5 mmHg.
Yeah.
But clinically significant problems, like varices forming, tend to happen when it gets higher, maybe over 10 or 12 mmHg.
Right.
When that pressure gets really high, the body desperately tries to shunt blood away from the portal system back to the heart via these alternative routes, the collaterals. And those small veins in the lower esophagus, which connect the portal and systemic systems, aren't built for that high pressure and flow. They stretch, dilate, become fragile. And those are your varices.
That makes perfect sense. The highway is blocked, so traffic floods the small side roads, which can't cope.
Perfect analogy. And remember, this same process can cause varices elsewhere too. Stomach, duodenum, rectum. Same mechanism, different location where portal and systemic veins connect.
Good point. So how common is this? What's the epidemiology look like?
Well, in terms of upper GI bleeds, esophageal varices account for about 10% of them.
Okay, so a significant chunk.
Yeah. And if you look at people with chronic liver disease, it's estimated maybe around 8% of them will develop varices over time. It's not guaranteed, but it's certainly a common complication to look out for.
Definitely. And the main way we find out about them, or the main issue, is when they bleed, right? How does that present? What are the symptoms and signs?
Yeah, the main clinical presentation is the complication, the bleeding.
So what might the patient actually experience or report?
They might have some abdominal pain, often upper abdomen. If the bleeding isn't massive or has maybe stopped for a bit, they might describe vomiting stuff that looks like coffee grounds. That's altered blood.
Coffee ground vomit, okay.
If it's an active, significant bleed, they'll likely vomit bright red blood. That's hematemesis. And that's usually more serious, higher mortality risk.
Right.
They might also notice melena, those black, sticky, Kari stools. That's digested blood from higher up. Or if the bleed is really fast and heavy, they might even pass fresh red blood from the back passage, which is called hematochezia.
So signs of bleeding coming out either end.
Exactly. And because they're losing blood, they might feel faint, or actually faint, syncope or pre-syncope. Sometimes weight loss, maybe difficulty swallowing, dysphagia, or pain on swallowing with dinophagia. But those are less common symptoms of the varices themselves.
Okay. And what signs might we see when examining someone, either during a bleed or because of the underlying liver issue?
During an acute bleed, you're looking for signs of shock. Low blood pressure, hypotension, fast heart rate, tachycardia, cool, clammy skin, maybe confusion, reduced urine output. All signs the body isn't coping with the blood loss.
Signs of shock, okay.
And then you look for the signs of chronic liver disease because that's usually the underlying cause. Things like jaundice, yellow skies, ascites, fluid in the belly, spider nevus, little red spots in the skin, maybe gynecomastia in men, or caput medusae veins around the belly button.
The classic stigmata.
Exactly. Less often, maybe signs of a tumor like a mass or swollen glands. A low GCS, confusion, could point towards hepatic encephalopathy, the liver failing to clear toxins affecting the brain.
Right. Encephalopathy is a big concern, too.
And crucially, always ask about alcohol. A history of significant alcohol excess in someone with an upper GI bleed should definitely make you think about varices.
Absolutely. Okay, another memory aid for those signs. Bleeding signs are shocked liver features, tumor clues, and gut troubles, just to try and link those observations together.
Helps keep it organized. Shock, liver signs, potential tumor signs, and the GI symptoms themselves.
Right. So if we suspect varices, maybe because of the history or the signs, what investigations do we do?
First off, blood tests are crucial. You want a full blood count, or FBC. That might show anemia, low hemoglobin from bleeding. The MCV might be high, suggesting alcohol use potentially. Platelets might be low, which is common in liver disease. White cell count might be up if there's infection.
Okay, FBC. What else?
Clotting screen INR is vital to check how well their blood clots. Renal function, UNEs, to check for kidney injury from the bleed. And definitely a group and save or a cross match, so you have blood ready if they need a transfusion.
Makes sense. Any imaging?
A chest x-ray is often done, mainly to check for aspiration pneumonia if they've been vomiting blood. But the key investigation, the one that actually diagnoses the varices—
GOGD.
Exactly, esophageal gastroduodenoscopy, putting a camera down. That lets you see the varices, see how big they are, see if they're actively bleeding, and importantly, treat them at the same time.
Right, see and treat.
Oh, and if they have ascites and you're worried about infection, like SBP, you might do an acidic tap to sample the fluid.
Okay, so OGD is the gold standard test. Good to remember. Now the critical part, management. Patient comes in actively bleeding from suspected varices. What's the approach?
It's the standard resuscitation approach first, like any major bleed. Think ABCDE.
Airway, breathing, circulation.
Exactly. Airway, make sure it's clear. Are they conscious? Is their GCS low? Might they need intubation, especially if there's encephalopathy or massive hematemesis?
Okay, secure the airway. Breathing.
Give them oxygen. Aim for SATs above 94%. Listen to their chest.
Circulation. This is key with bleeding, right?
Absolutely. Get access. 2 large-bore IV cannulas minimum. Start fluids immediately. Rapid boluses of crystalloid or colloid to get that blood pressure up. Send off those bloods we mentioned, FBC, clotting UNEs, cross-match, maybe a venous blood gas too.
And blood transfusion.
Yes. If they're actively bleeding and unstable, don't wait. Give blood. If cross-matched isn't ready, use O negative. Keep a close eye on their heart rate, BP, urine output. They'll likely need a catheter. Continuous cardiac monitoring.
Disability and exposure.
Disability. Check their GCS, pupils, blood sugar, exposure. Fully examine them. Look for those liver signs. Check temperature. Okay, so stabilize first using ABCDE.
Yeah.
What about specific medical treatments straight away?
Right. If their INR is high, especially if they're on warfarin, give vitamin K. If it's really high or they're bleeding massively, they'll need FFP or fresh frozen plasma. Consider activating the massive hemorrhage protocol if needed.
Okay.
And crucially, talk to the experts early have, the GI bleed team, gastroenterology. Follow the NICE guidelines. Start terlipressin as soon as you suspect variceal bleeding. Terlipressin, that's the vasoactive drug.
Yes. Helps lower the portal pressure, usually 2 milligram IV every 6 hours initially. Also, start prophylactic antibiotics broad spectrum, according to local policy. This reduces infection risk and actually improves survival.
Antibiotics, right. Anything else?
Often a PPI infusion is started too, like omeprazole. Calculate their Glasgow-Blatchford score. It helps predict risk. Try to avoid sedatives if you can. They can worsen encephalopathy or mass deterioration. And get them to a higher level of care, early HDU or ITU. These patients can go downhill fast.
Okay, that's a lot, but it's a structured resuscitation. Then, stopping the bleeding directly, that's the OGD, the endoscopy.
Exactly. Urgent OGD, ideally within 24 hours. The main treatment during endoscopy for bleeding esophageal varices is band ligation.
Banding, putting little rubber bands on them.
Yeah, sucks the varix into a cap, fires a band around its base, strangulates it. It's generally preferred over the older method, sclerotherapy, which is injecting a substance to scar them up. NOICE recommends banding for esophageal varices.
So banding is the go-to. What if it's gastric varices in the stomach?
For bleeding gastric varices, NICE suggests considering injection of N-butyl-2 cyanoacrylate, basically, a special type of glue. It can work well, but does carry a small risk of the glue traveling elsewhere, embolization.
Okay. And you mentioned terlipressin earlier. What are the key nice points about using that?
NICE says offer terlipressin to all patients with suspected variceal bleeding, even before endoscopy confirms it. Start with 2 milligram IV QDS. Then once bleeding is controlled, reduce to 1 milligram Q4H, usually for up to 48 hours total. Stop it once hemostasis is achieved.
And the antibiotics.
Give prophylactic broad-spectrum antibiotics as soon as you suspect or confirm variceal bleeding. Definitely recommend it.
Good. What if banding and drugs don't work? What if the bleeding continues?
That's when things get serious. You might need temporary measures while planning definitive treatment. One option, though used less now, is the Sengstaken-Blakemore tube.
The balloon tube.
Yeah. It has balloons you inflate inside the esophagus and stomach to physically press on the varices and stop the bleeding. It's a temporary salvage measure, really. Carries risks like aspiration or esophageal rupture, needs careful monitoring.
A bridge to something else.
Exactly. The main something else, if endoscopy and drugs fail, is TIP-PS.
TIP-PS, transjugular intrahepatic portosystemic shunt.
Right. It's a procedure, usually done by interventional radiologists. They create a channel, a shunt, within the liver itself, connecting the high-pressure portal vein system directly to the low-pressure hepatic vein system.
How do they do that?
Usually via the jugular vein in the neck. They guide a catheter down through the heart into the hepatic veins, then puncture through the liver tissue into a branch of the portal vein and deploy a metal stent to keep the channel open.
Wow. So it bypasses the scarred liver.
Essentially, yes. It diverts blood flow away from the portal system, dramatically lowering the pressure and therefore reducing pressure in the varices. It's very effective at stopping refractory bleeding, but can have complications like worsening hepatic encephalopathy.
Okay, so TIP-S is the big gun for uncontrolled bleeding. Let's summarize that initial management. Rhesus, ABCDE, drugs, terlipressin, antibiotics, PPI, scope band, consider TIP-S.
That covers the key steps nicely. Resuscitate, give the initial meds, get the scope done for banding, and think about TIP-S if that fails.
Perfect. Now, what about preventing the first bleed or preventing rebleeding? What can we do long term?
Good question. For primary prevention stopping the first bleed, we mainly use non-selective beta blockers like propranolol or carvedilol.
Beta blockers, how do they help?
They reduce cardiac output and cause some vasoconstriction of the gut circulation, which together lowers portal pressure. They're often used indefinitely if patients have medium or large varices, or even small ones if they have high-risk signs like red spots.
Okay, beta blockers are key. What if someone can't take beta blockers?
Then endoscopic band ligation can be used as primary prevention too, especially for medium or large varices, basically banding them before they've had a chance to bleed.
So banding can be for treatment and prevention.
Yes. And there's evidence that monitoring the hepatic venous pressure gradient, the HVPG, and reducing it with drugs can improve outcomes. Also, screening endoscopy is recommended for everyone newly diagnosed with cirrhosis to find varices early.
And after someone has had a bleed, secondary prevention.
Definitely need long-term treatment, usually a combination of non-selective beta blockers, sometimes with nitrates added, and regular endoscopic surveillance with repeat band ligation as needed until the varices are obliterated.
So ongoing management is crucial to prevent rebleeding. What's the overall outlook, the prognosis for people with varices?
It's serious, unfortunately. There's significant morbidity and mortality associated with variceal bleeding. The outcome really depends on how bad the underlying liver disease is. The Child-Pugh score is often used to assess this and the cause of the portal hypertension.
Are there signs that predict a worse outcome?
Yeah, large varices, especially those with red spots or red whale signs on endoscopy, are higher risk for bleeding. And as we said, the rebleeding rate is high, maybe 70% risk within a year or two if no secondary prevention is used after a first bleed. Patients with child QC cirrhosis, that's severe liver dysfunction with jaundice, bad ascites, encephalopathy, they have a much poorer prognosis.
Okay. And the main complications we worry about?
The biggest one is severe life-threatening bleeding. That's the most immediate danger.
Right.
Infection is another major risk, especially bacterial infections like SBP or pneumonia, often precipitated by the bleed. That's why prophylactic antibiotics are so important.
Makes sense.
Hepatic encephalopathy can be triggered or worsened by the bleed and the associated metabolic changes. And ultimately, sadly, death is a significant risk, especially with severe underlying liver disease or uncontrolled bleeding.
Okay. Finally, just to round it off, when someone comes in with upper GI bleeding, varices are high on the list if they have liver disease, but what else should be on our differential diagnosis?
You always have to think broadly with upper GI bleeding. Peptic ulcer disease, gastric or duodenal ulcers is very common.
Ulcers, yeah.
Gastritis, duodenitis, inflammation of the stomach or duodenum lining. Mallory Weiss tears, which are tears at the junction of the esophagus and stomach, often after forceful vomiting.
Okay.
Less commonly, things like esophageal or gastric cancer or bleeding from vascular malformations like Dieulafoy lesions. So, while varices are critical to consider, especially with liver disease signs, you need to keep other possibilities in mind until the endoscopy confirms the source.
Excellent. That's been an incredibly thorough run-through of esophageal varices. Just to hammer home the absolute key takeaways for revision, we're talking dilated veins, lower esophagus, caused by portal hypertension, usually from cirrhosis. The danger is bleeding hemidemesis, Malina-Rot. Management starts with ABCDE resuscitation, then give terlipressin and antibiotics early, and the key intervention is urgent endoscopic band ligation.
Absolutely. Understanding that link between the liver disease, the portal pressure, and the varices, recognizing the bleed, and knowing those initial management steps, that's the core knowledge you need. It's highly relevant stuff for exams and, more importantly, for looking after patients.
Couldn't agree more. This has been really clear, hopefully very helpful for everyone listening. And if you are looking for more resources, especially for MSRA prep, do check out passthemlra.com.
And there's also freemsra.com for, well, free resources too. Definitely worth looking at both.
Great stuff. Thanks again for joining us for this deep dive, and we'll catch you on the next one.